Hello, my name is Alex Jones, a chief resident at UT Southwestern Medical Center in Dallas, Texas. On behalf of myself and my co-authors, I would like to thank the GIE editorial board for the opportunity to highlight our recently published manuscript entitled The Clinical Utility of Incorporating Next-Generation Sequencing into the Management Algorithm of Pancreatic Cysts. I have here with me my co-author, Dr. Tarek Sawas, an assistant professor and the Advanced Endoscopy Fellowship Program Director here at UT Southwestern. So, Dr. Sawas, what challenges do providers face when managing pancreatic cysts?
Thank you, Alex. So the incidental finding of pancreatic cysts has increased dramatically in the last decade because we're doing more cross-sectional imaging. As patients come to our clinic, they're very anxious because they're worried about their risk for pancreatic cancer, which has really high mortality. It's not always easy to distinguish mucinous from non-mucinous cyst, and even if we prove that a cyst is a mucinous, it's not easy to predict which ones are high risk for progression and which are low risk for progression. On the other hand, the morbidity associated with surgical intervention for these cysts is high, which also not an easy decision for a patient to make.
So, how are pancreatic cysts managed currently, and where are the gaps?
Yeah, there are several guidelines that you can use clinically. The one we use in our clinic is the International Association of Pancreatology Guidelines and the revised version of Kyoto. These guidelines use a combination of imaging, laboratory, and pathology to risk stratify patient. Based on this, you can either recommend surgery or surveillance, and the interval of surveillance is determined based on the size of the cyst. However, there has been multiple studies that show that these guidelines are not very accurate in detecting the risk for progression. This means there will be patients with low risk who might undergo intense surveillance or surgery. And there will be some patients who are deemed low risk, where in fact they harbor malignancy.
So, what approach do you follow to mitigate this gap?
So our clinic uses the next generation sequencing test as part of our management algorithm. The NGS test we use is called PancreaSeq. We sent it to the University of Pittsburgh Medical Center, UPMC. The test reliably distinguishes mucinous versus non-mucinous cysts by detecting KRAS and GNAS mutations in a mucinous cyst. On the other hand, if you detect VHL, this is a serous cyst adenoma. It also detects multiple high-risk mutations, such as P53 and SMAD4. If these genes are detected, then these are cysts that have higher risk for progression into advanced neoplasia and potentially cancer.
So, what was the aim of this study?
So the utility and the diagnostic yield of pancreatic sequencing has been reliably shown in multiple previous publications. The current study that we performed aimed really to look into the clinical implication and the changes in clinical management by integrating NGS in clinical practice and the management algorithm.
So, how did NGS change management for patients in this study?
NGS changes management by two ways. By determining the type of cyst, mucinous versus non-mucinous, and by risk stratifying cysts into low risk and high risk. So historically, we used to use CEA as our way of detecting whether a cyst is mucinous or non-mucinous. But this method lacks sensitivity. So now we rely on next generation sequencing. By detecting genes like KRAS and GNAS, then we determine that a cyst is mucinous cyst, and that would require surveillance. On the other hand, if we detect that a gene is VHL, then we know that the cyst is serous cyst adenoma, which does not require surveillance. Similarly, if we detect high-risk mutation like P53 or SMAD4, that means that the cyst is high risk for progression into high advanced neoplasia and would require surgical consideration or intense surveillance.
So, how did using NGS guide surgical management for these patients?
So NGS in our cohort helped really dramatically with the surgical decision. We had a total of 42 patients who underwent surgery. Of these 42 patients, 28 had high-risk features or multiple worrisome features and would have gone to surgery regardless. The remaining 14 patients did not have high-risk features. However, when NGS was performed, high-risk mutations were detected, and they undergo surgery because of NGS. On the other hand, we had 20 patients who were borderline surgery, and surgery was considered in them. However, when we performed NGS, no high-risk mutations were detected, and therefore they underwent surveillance only. So these patients were saved from surgery because of NGS.
And were there any other populations besides those with side branch IPMNs who benefited from NGS?
Another important cohort is patients with dilated pancreatic duct. It is often difficult to distinguish dilated pancreatic duct between main duct IBMN and dilation from benign etiology like chronic pancreatitis. And there are significant ramifications downstream based on the diagnosis. One of them would require surgery, the other one would not. One of them has a risk for cancer, the other one does not. So in our clinic, if we are suspecting that a dilated pancreatic duct could potentially be a main duct IBMN, we perform ERCP and we aspirate fluid from the main pancreatic duct. We send it for next generation sequencing. If the fluid comes back as KRAS or GNAS positive, this supports the diagnosis of main duct IBMN. Or if a high-risk mutation is detected, also that's concerning for a neoplastic process. And we deal with these patients as main duct IBMN, and they undergo surgical consideration. On the other hand, if no high-risk mutation or no KRAS or GNAS mutation is detected, then we assume a benign etiology, and these patients either undergo surveillance or just got managed as chronic pancreatitis. In our study, we included 27 patients with dilated pancreatic duct. Out of these 27 patients, 13 had NGS mutation and supporting a diagnosis of main duct IBMN. Of those, 7 underwent surgery. On the other hand, there were 14 patients who did not have mutation on their NGS, and these patients were managed conservatively as a benign etiology.
So based on our discussion, we can conclude that incorporating next-generation sequencing into the pancreatic cyst management algorithm changed management for over one quarter of patients in our study. In particular, we highlighted 3 patient populations that benefited the most from NGS. Those with high-risk NGS mutations who had no other clear surgical indications and underwent surgery as a result of NGS. Those with NGS resulting in the diagnosis of a non-mucinous cyst when the nature of the cyst was otherwise unclear, supporting no need for further surveillance as their cyst was deemed to be non-cancerous or not pre-malignant. And finally, those with dilated main pancreatic ducts of unclear etiology where NGS revealed no genomic alterations, suggesting the absence of main duct IPMN and supporting conservative management as a benign etiology such as chronic pancreatitis. We'd like to thank GIE again for the opportunity to share our study.